Thank you so much for having me at this conference. I'm really enjoying learning from everybody and such a distinguished panel of guests and speakers. My name is Aviva Rosenberg. I am the other co-founder and co-president of Gaucher Community Alliance, and we are so grateful to be here today. My presentation, for my topic, I'm going to be talking about the financial impact of COVID-19 on our patient community, and to give everybody some things to think about. That's just, for some of us, the financial impact is really just beginning, and why it might be a little different for rare disease patients, specifically Gaucher and other LSD patients, than maybe some people with some more general diseases. So hopefully during this time, when you're finished, you'll understand how important it is for health insurance for rare disease patients, and why that provides a lot of anxiety if there's a loss of insurance or even just a change of insurance for patients that have rare diseases. It's just the act of changing insurance or having to have a new insurance plan provides a lot of anxiety and a lot of the time commitment as well. In addition, I want to talk a little bit about home health and sort of the challenges that our patients are facing with that, that are new during this COVID-19 time. All right, so just to set some background, as everyone here knows, the United States system is an employment-based healthcare system, which is very different than much of the world. So the most recent year in 2019, we still have close to 50% of Americans receiving health insurance through their employer. So now, 10 or 20 years ago, this number would have been a lot higher as companies have tried to get their costs down and get people off of their plans. But the reality is that there is still 50% of us are receiving our health insurance through employers or spousal employers. The 5 states that have the greatest number of people with employer-sponsored health insurance are typically, the biggies. So you see California, Texas, New York, Florida, Illinois, and you can look at those and these are the big states. This is also where we have a lot of a patient population. So it's pretty useful to assume that many or the majority of our patients receive their health insurance through either their employer or their spouse's employer or their parent's employer. So the most recent year we have data is 2018, and so only 8.5% of Americans did not have any health insurance. So this isn't just employment, this is just whether Affordable Care Act plan or government, or so only 8% of Americans did not have health insurance. And this is a huge decrease from the Affordable Care Plan. But about 20 years ago, or when I was learning in health policy school, the number that we always threw around was 20%. There was approximately 20% of Americans did not have any health insurance. And this also includes government plans. So if you have a government plan, you have health insurance. But about 20%, so 20 years ago, 20% of Americans did not have any health insurance. And now, since the Affordable Care Act passed, and you have the ability to buy insurance plans on the exchanges, in addition to Medicaid expansion, you're down to only 8%. So that's a huge improvement, and it's been really, really good for our community and for patients with chronic health conditions in general. We've been able to eliminate the pre-existing conditions. We've been able to move between jobs or purchase plans on the exchange. So this is all good news. The one thing that this assumes is that you have the finances to purchase the plan on the exchange. And of course, if you lose your job, that often is not the case. So let's talk a little bit about what's going on right now in this country with this pandemic. In May of 2020, the unemployment rate was 13.3%, which is approximately 10% higher than a year ago. So I'm sure all of us we know someone that's lost their job. We know someone whose hours has been cut. It really, almost every industry has been touched by this. Even in some industry, healthcare is typically an industry that, you think you go into healthcare, you're always going to have a job. Well, you have health systems laying off hundreds and hundreds of nurses, furloughing technicians, doctors are losing their jobs. And then of course, all of the employees that service that health system, service workers as well, are losing their jobs. So every industry has been touched by this pandemic, and the job losses are really staggering. And this is just the beginning. You have some industries that might see the fallout farther down the road, and hopefully you'll have people going back to work as well. So and then there's the second bullet talks about the people that are cut. They've gone from full-time to part-time, because they've had their hours cut. And so this group of people who, may not be receiving health insurance through their jobs to begin with is now making a much lower income. And if you have to decide between, putting groceries on the table or paying for your health plan, that's a really hard decision to make. You're probably going to need to feed your kids. So why is this important? Why are we talking about this here at this conference? If you have a rare disease, there is really no question that you need to have a health plan. You need to have a health insurance. You cannot get by. Heart disease, there's certain heart disease drugs, diabetic drugs. You could pay $60 a month. It's hard, but you could do that and still get by. But if you have a rare disease, you cannot pay that out of pocket a month. Patients cannot do it. You need to have a health plan. So just for example, the average cost for a rare medical condition is $120,000 a year. So that's 25 times more expensive than a traditional drug to treat a more common illness or ailment. Orphan drugs, which are defined, treats a population for less than 200,000 individuals in the United States, which pretty much every LSD is in that category. So the average annual cost for that type of drug is $186,000, and that's 2017 numbers. So it's probably gone up some since then. So as I've mentioned, it's completely impossible for a patient to afford treatment, even temporarily, if they do not have an insurance plan. So if you're in between jobs, you lose your job, you're temporarily furloughed, and your insurance benefits cease, then you're not going to be able to continue that treatment. Even you can't just pay out of pocket for a couple months. At least most people can't. In addition, even if you have a new job, or if you have a new insurance plan, you lost your employment insurance, but you have another job, so you're able to get a new plan on the Affordable Care Act exchange. Just that switching, it's not, when you switch insurance plans with a rare disease, it's never seamless. You're going to have some lag time because the new insurance is going to require all the pre-authorizations. They don't know you, and all of a sudden they're getting this bill for $30,000 a month medication. So they need to have all the insurance and all the specialized forms from your physicians and from your care managers, from the patient's care managers, to make sure prior to the drug. So there's there's going to be a lot of movement, and it's during this pandemic recovery time, and it's going to involve job movement, job loss, underemployment, and ultimately different insurance plans. And so patients are worried. We've heard from several in our community. They know, they're currently on extended benefits. They've lost their job, but their employer gave them, 90 days of insurance, and they're looking for a new job. So even if the patients haven't quite lost their insurance yet, a lot of them know that it's coming, as employers are struggling with their cuts and their lower payments. And so, this is a very, very stressful time for our community, for those that are dealing with health insurance changes. In addition, a lot of people, think that, okay, well, if I lost my job, maybe I can just qualify for Medicaid. It's not that simple, and it varies from state to state. But in general, Medicaid, you could be a pregnant woman or a child. So those people can often qualify for Medicaid in most states. But just because you've lost your job and your income for the current year is down, you don't qualify for a state plan. It has to do with levels of poverty, percentages of poverty, and it's often very, very hard to qualify. Another way to qualify is a disability. But again, that takes years to do for someone that had, and not everybody that has a lysosomal storage disorder or Gaucher disease necessarily qualifies for disability to get onto a Medicaid plan that way. So the bottom line is that we need health insurance, we need consistency, and during this recovery and incredible job loss and movement of employment and people, our community is concerned, and there'll be a lot of changes. And there'll be some breaks in treatment, which for some people is okay, and for other people could really be very detrimental to their health depending on the length of time. Moving on to slightly different issue, I want to just address some home health care challenges that also deal with insurance and finances. So many times rare disease treatments require in-facility components. So whether they're infusions or other injections or some other type of treatment, patients often do go to an actual building rather than having it at home. In addition, so Medicare, so for our community members that are over age 65 and on an infusion treatment versus an oral treatment, Medicare has a requirement that these patients must go to infusion center. They can only have home health treatment if they are what's called homebound. And to be certified as homebound generally is a pretty severe condition. So some doctors are currently certifying that their patients are homebound because of the quarantine, although that's not typically what the regulations mean by homebound, but that's for elderly patients that are very scared to get their treatment or to go to the clinic or the hospital to get the infusion. That's one way to look at it. Not that I'm recommending that. In addition, if you are receiving home health, if you are newly diagnosed, patients that are newly diagnosed or patients that are switching treatment, their current treatment is not working for them, you cannot do that at home. If you're new to a treatment, or if you're trying something different, that all has to be done in a clinic, so you could be very carefully monitored. It's not as easy as taking a Tylenol. Sometimes there are severe reactions with these complicated treatments, and so it all involves going into a clinic. So what does this mean? Well, people are nervous. I think that the healthcare system has not fully communicated to our community that they can keep patients safe. The healthcare system and the industry needs to do a better job of telling patients that you can come here for your healthcare and you will be safe and you don't need to worry about COVID-19. And so there's many reasons that patients do need to go to a healthcare system, and they're not going. I have community members saying they're not leaving their house until there's a vaccine, which, as we know, can be quite a while. So you have people skipping treatments. You have patients not getting other types of testing that they need done, or delaying possibly a better treatment for themselves. So the takeaway, this is a situation we're all in it together, and if there's a few things that as providers you may want to think about. Obviously encourage home health care. If it's possible for patients to receive their care at home, that is probably best for right now, just to minimize the risk. But at the same time, if you're in an area that is lower community transmission, you should encourage your patients to continue their treatment. Ultimately, that may keep them healthy longer. Another item is check in with your patients on their insurance coverage and make a plan. So if the patient knows that they're losing their benefits in 90 days, now's a good time to come up with a plan, instead of I lost my benefits last week, I can't get any more medicine. That's usually when you're in panic mode. And so a better solution, we believe, would be to come up with a plan on what's going to happen when the benefits run out and what's the next steps. And then finally, for our community members and our patients that are in isolation, They're lonely, especially the elderly, the elderly people. They're scared and they're lonely, and they're, you know, they're not seeing their families, and they're not getting their treatments, and so their health is declining on multiple levels, and their mental health needs, you know, should be considered at all points. So it's a lot to think about, and I thank you very, very much for listening, and I really believe we're going to get through this together, and our patient community is thankful for all of the care and help that you provide us. Thank you.